All right, welcome back to the 4 o'clock session. So we talked about some kid emergencies. Now we're going to talk about go back a little bit in time, do some postpartum emergencies. So a couple more to go left today. So Chris is back with us again. So here we go.
Yeah, here we go again. Sounds good. Those of you that weren't in my first session, just to give you a little bit on me, I have been a medic now for going on 27 years. I've been teaching for about 26, and I am currently the lead EMS instructor for the University of Toledo's EMS program here in Toledo, Ohio. And what we're going to talk about for the next hour is something that you may come across in your career quite often, depending on where you are. You may be like me and have never really taken care of a lot of these people. Seen a lot, but never really had much pre-hospital care. It was more critical care transport and things like that. And it's these patients that have issues, females, after birth. And there are quite a few different types of things that can occur. So we obviously don't have time to go through all those. But I just want to run through a few that you're probably likely to come across more so than not, and what we can do about them. And a couple of these actually might surprise you because most people think that they actually happen during pregnancy, not after. So that being said, this over here, there we go. All right, so we're actually going to talk about preeclampsia and eclampsia. And that really, again, kind of shakes some people because it's like, wait a minute, that stuff happens while they're pregnant, not after. But we're going to talk about how it actually does occur afterwards. And in some cases, it's actually worse after pregnancy than during. We'll talk about more than likely one of the more common things you'll come across, which is a postpartum hemorrhage. We're also going to talk about this more of a rare condition that's called a postpartum cardiomyopathy. And I say that again with a grain of salt because the very first time I presented this, I had 5 women in the audience come up to me and they all had this. And statistically, that was probably the only 5 people in the state of Virginia that actually probably had it in that year. So it was interesting how that actually worked out. But it is something that does happen. It is something that is relatively rare. But again, depending on where you are, this might be something that occurs more often than not. And then we're also going to talk about these different types of emboli that could happen. Not only just a pulmonary embolus from a clot or things along those lines, but also something along the lines we're going to talk about, which is called an amniotic fluid embolism. And this can happen also during pregnancy, but can also manifest afterwards. All right. So we got these different periods after birth has occurred. And this postpartum period, or what's called a postnatal period sometimes, typically in most literature, they give it up to about, a month and a half after birth has occurred. What's happening here is that obviously everything that was thrown out of whack for the last 8 or 9 months, give or take, is now trying to revert itself back to normalcy before the pregnancy occurred. And a lot of those changes, most women will take care of very, very easily. There'll be no complications and will never be cold. But there are those that will not have that luxury, and these are the patients that we're going to see. So unfortunately, during this time, according to the World Health Organization, this is usually where most of the maternal deaths will actually occur. So this may be that patient that we get in cardiac arrest that had just been given birth recently. And it's unfortunate, but because of some of the things we're going to talk about here, it also makes it more likely. And those are the things that we have to kind of be dealing with these types of patients. So we take that month and a half period and we kind of divide it out into a couple of different subperiods, if you will. And the one which is called the acute or initial period, this is anywhere from the first hours up to about a week, give or take. And what tends to happen in general is about the 3rd day after birth tends to be some of the more difficult ones. And it's what you see in that graph right there, is that a lot of their elevated hormone levels that were necessary for the birth process and obviously maintaining the gestational period, well, we don't need them in those high levels anymore. So the body says, get out of here. So they drop off. And as you can see, they drop off pretty precipitously. And because of that harsh change in those levels, that leads to a lot of mental health types of issues, Postpartum depression starts to set in. In certain cases, they just can't shake it, and it tends to linger. Sometimes it's only for a couple of days. It, again, varies. But what also is more likely to happen in this time period is what you see here, where the bleeding is going to be present. Now, there is a certain amount of bleeding that's expected, regardless. However, this would be a period where now that bleeding is in more volume than what's expected. And so that patient may be becoming hypovolemic or anemic as a result. And that may be something we have to deal with. This may also be a time where that fluid embolism from the amniotic fluid may manifest. And the only reason being is just time. Some of these types of emboli, as we're going to talk about, they're filled with byproducts of the amniotic fluid. And amniotic fluid has a whole bunch of stuff in it. It's got fetal cells, it has hair, it has nails, it has other byproducts that are in the amniotic fluid naturally, fecal material in some cases as well. So all that tends to solidify, and when it gets into the cardiovascular system, it's almost like fat where it'll eventually keep moving, but it's just going to take its good old sweet time. And in some cases, it just takes this longer period of time, but now we get called for this patient with that acute shortness of breath. This is where that, again, that preeclampsia and eclampsia also may start to rear its head, as well as you may have a uterine inversion occur. Relatively rare, but still may happen. And this is just, again, from that lack of muscle tone that doesn't kind of catch back up with the patient. The second phase, which goes up to about the end of the period, which is called the subacute phase, this is where a lot more of the types of issues with the urinary system, the reproductive system, their metabolism, and again, even their emotional status tends to manifest here. Everything is basically reverting back to normal, as I said, but here it's just trying to really work on doing so. So it doesn't occur as rapidly in that first week. Here now it's kind of picking up some speed. So now you have that patient that may have a lot of different variable presentations, most of which we're never going to get called for, but they may be there. So on your exam, if you're there for something else or even something related to this, they may complain of, again, either genital or perineal itching or discomfort. And a lot of that's just from the stretching in the birth process that occurred. Maybe they had a tear and it's still healing, those kind of things. Hemorrhoids, constipation, abdominal pain, not being able to go to the bathroom, and those kind of things. Mastitis, which is a inflammation, irritation of breast tissue from an infection. They may have, again, pain, abdominal pain from endometritis. They may have retained some placental parts that, unbeknownst to their OB, or maybe they gave birth naturally at home and with a midwife of some sort, and perhaps, again, stuff was missed. It happens from time to time. UTIs also occur from this. But this is also where we might see that cardiomyopathy, which is called pericardial cardiomyopathy, start to actually manifest. And it usually occurs very prominently in females that have no heart history. And the cardiomyopathy is not genetic in this case, it's actually secondary to the fact that they were pregnant. And we'll kind of talk about that towards the end. All right. Now, as I said, most of the actual postpartum types of things we're going to see are in those first 6 weeks. However, there is this delayed period that gets mentioned quite a bit where it can last in upwards of almost 6 to 6 months after birth. Not a lot of stuff really happens here catastrophically to the patient, so there may be some associated discomforts and things like that that occur because of the body getting back to normal. But these aren't things we're going to get called for. Like I said, these are things we're probably going to get told when we're doing an assessment for more than likely something totally not related to the birth at all. But it's just something to think about. All right, so I got about 4 different cases here we'll run you through, and these are cases that are likely to be as very similar scenarios when you get called out. So the first one is, got a 32-year-old female, been home for about 4 days, and she delivered a relatively large, child 4 days ago. She's been pretty active, but she has had that increasing amount of bleeding after her first day, as I said, which is kind of normal. Okay, however, her bleeding volume has gotten worse over the last couple of days. And you're called because when she got up in the middle of the night to take care of the baby, her husband heard her collapse, basically. She had fainted in the hallway and thus called 911 because, well, doesn't know what to do. So we show up. This is what we find. So you've got pale, cool, clammy skin. Her pressure is not all that glorious. She's tachycardic. She does have decent pulse ox, but she is altered. So if you're looking at this from the fact of what we've got in our history here, you can probably make the very good assumption that the volume issue has led to some type of shock state. And as a result, she dropped her pressure, and that's when she got up and passed out, and here we are. So the point is, well, what are we going to do about it? Well, as I said, this is probably one of the more common types of calls we'll get because of the bleeding that's either quite pronounced or just prolonged in these cases. So typically how this gets defined is that you have that typical blood loss anyways, and we usually expect about a half a liter on a patient who's doing a vaginal delivery. If there's more than that, or if it's continuous for a number of days past the birth, then this is where we start seeing these problems. If it was a C-section, we typically give them a little more leeway and we give them up to about a liter. But even then, after that, we still may be seeing that symptomatic patient, and they fall into this category, which is a primary postpartum hemorrhage. This is the one that, like I say, is very common. This is also the one when we talk about the most maternal deaths. It's about a quarter of all the annual deaths in this particular population. So it is a very high number of people that we'll see. And unfortunately, most of this bleeding is internal. So it's very hard to control. These people end up being surgical cases. So it's a recognize, stabilize, and transport scenario in the vast majority of cases. Now, as far as causes go, there are 4 major causes behind this postpartum hemorrhage. And you can think of it as what they call the 4 T's. So that's tone, trauma, tissue, and thrombin. And in that order from top to bottom, they're more popular and then become less popular. So an atonic uterus is just that. It's the muscle in the uterus in and of itself just doesn't contract very well at all, or so slowly that the bleeding is pronounced because it can't stop because there's nothing to tampen on it. Trauma goes without saying. The tissue is that retained tissue we talked about. So now we're looking at the endometritis type of scenarios, perhaps, or you have what's called an invasive placenta, which leaves products behind. And we're going to show you those here in just a second. And then lastly, any kind of coagulopathy, which is problems with clotting. So let's look at the atonic uterus first. And being that this is the more common, as you saw, this happens in about 1 out of every 20 deliveries. So it's one of those things that if it doesn't happen, people are a little more surprised than if it does. But a lot of different causes can lead to this. One is that they just have a lot of babies on board. You know, if you're Nadia Suleiman that you see there in that top picture, you know, AAK, the Octomom, if you've got 8 babies in there, you've got a uterus that's got to make room for all of them. And so there's a massive amount of stretch. Obviously, it's going to take a lot longer for it to get back to normal size if it does at all. Prolonged labors, or a labor that was just the opposite. It was very, very fast. That, again, may have issues with uterine tone. If they used oxytocin, so that's something we find out in the history, Pitocin, which is a induction agent to stimulate the muscle to contract. Maybe if that was used, again, may be part of the problem. The fact that they have had multiple children. So if your last name is Duggar or something similar to that, where you have 15, 16 kids, the uterus over time just never really recovers because of the constant pregnancies and obviously the stress and strain that it's under. Administration also of mag sulfate, high birth weights, and obviously you have the high risk type of patient, which is over 35 by definition. Those also may have something to do with this tone of the uterus that just does not snap back and constrict. And as a result, it allows for bleeding to occur a lot longer. It's also part of the reasons why you hear about people trying to do that fundal massage and things like that on your patients. Yeah, we're trying to stimulate that muscle to try and, well, contract. go back to this. If, for example, they were given a bunch of magnesium sulfate because maybe they were preeclamptic for whatever reason, magnesium sulfate is a soft tissue and soft muscle relaxant, smooth muscle relaxant, sorry. Uh, Enough of it in there, it may just take a while for it to wear off. And the muscle isn't going to contract because the medicine's not going to allow it to. And there you go. So as I said, history, your exam is going to give you a lot of indications as to maybe why they're continuously bleeding. Trauma is the other one, like I told you, that's the second down the list. They may have had a tear. And this might be part of the recovery we talked about during the postpartum period, where they had to have it surgically repaired, and that's where the itch and the discomfort and all that comes from. But depending on what type of tear they have, they're going to bleed obviously much more with a third or fourth degree tear than, say, you know, a first or a second, like you see in these pictures here. They're all painful. They're all going to bleed, but they're all basically managed the same way, which is direct pressure on the outside and trying to control the bleeding as best as possible in that regard. All right. Another part of this trauma maybe is that you've got a uterus that has inverted itself. And as I said, this is not something that happens very often, but it can happen. And when it does, this is not only a bleeding issue, but it also is a life-threatening issue because it can also cause the patient to drop their heart rate very, very quickly. Why this happens? Well, again, tone of the uterus might be part of it, as we mentioned earlier, but it could also have been secondary to where the placenta was implanted. If it was implanted on the top part of the uterus, just by the natural birth process, it may have pulled the uterus with it when the fetus was delivered. The other thing might be is this is why we're always told never to pull on the umbilical cord, try to pull it out after birth. One, because I just don't need to, but B, when you do and you put that traction on there, no matter where the placenta has been implanted, you might inadvertently start pulling the uterus with it, and that's just not a good thing, right? Now, that being said, here's the issue with the uterus being inverted. So the uterus is obviously in front of the sigmoid colon and the rectum in the female. If you've ever had a patient or you've helped a patient that's been, say, in SVT, and your medic or you tell that patient to bear down like they're going to have a bowel movement. Right? Now, when they do that, they're inadvertently activating these muscles that you see circled here, which is the internal sphincter muscles. These are also the muscles that we use to kind of quote unquote hold it or pinch it off so that we can make it to the bathroom. Right? Now, the problem is that if you overstimulate these muscles, right, they're controlled by part of your parasympathetic nervous system. Now, what's the big deal? Well, that uterus now that's relatively large, if it starts coming down versus staying where it's supposed to, it can inadvertently press up against these muscles, and as a result may inadvertently activate the parasympathetic nerves that are located in this muscle. If they are stimulated enough, these nerves will send a signal back to your brain to release a chemical, which is called acetylcholine. And acetylcholine then gets released into the bloodstream, and if it gets to the heart, it basically tells the heart to slow down. Right? And the heart doesn't have a say in it, it just automatically does. So now your patient starts progressively getting more and more bradycardic, their output drops, their blood pressure drops, and problems occur from that. Right? So it is something that can be very dangerous, and it might be in that case where you may be advised, especially at the advanced level, to try and reinsert the uterus. Now, that is something that is going to be a last-ditch effort, but it is something that you may be told if you have a long transport, and it's very, very difficult and very, very gross, to put it mildly. But it may be the one thing that at least takes the pressure off this area that allows that patient to at least increase their blood pressure by increasing their heart rate, and it may buy you some time. But that would be a medical control thing, and you would probably be talked through it if and when that ever came to pass. Another part of the trauma issue may not be that the uterus was inverted, it may actually have been ruptured. And this could have been possibly occurring while the baby was in utero anyways, from some type of blunt injury to the abdomen. but simply because of the fact that maybe this patient had a C-section in the past. Now, for whatever reason, most people that have C-sections, they can't deliver vaginally, and that's why they get them. But if that's not the case and the C-section was for another reason, maybe mom was crashing or they had to get the baby out quickly for whatever reason, maybe now in this second pregnancy, she is able to deliver vaginally and is doing so and did so in this instance. Now, the problem is that if there had been a previous C-section, it creates a lot of scar tissue and it's a weak spot in the uterus. Now that second time or that third time or whenever mom's contracting, it may tear that tissue. And as a result, you get a scenario that looks like this picture right here. And that uterus starts to bleed, and it bleeds, and it bleeds, and it bleeds, and it bleeds. Right? And a lot of that blood may be retained internally, so what you're seeing on the outside may be nothing in comparison to what she has on the inside. If she looks like and presents like she's in a shock-like state, she is. And again, history may dictate in this case that this may be a possibility. You try to control the bleeding as best you can externally, try to manage her with her internal bleeding as best as you can based on what you're able to do. And again, it's a precipitous transport because this is going to be a surgical case. What about tissue? Well, this invasive placenta, like I told you, in some cases, it may be just placental tissue that's retained, but if they're in the hospital, the vast majority of the time, either through a DNC or just through natural elimination, those placental pieces are gotten rid of. However, if it's something like this was a scenario, the likelihood they retain pieces may be a little bit more likely. And so now it just, again, keeps the clotting factors activated, and again, you may have some bleeding that results from it. There are three basic types, and it basically depends on how deep the placenta embedded itself in the uterus abnormally. Right? So if it adheres to the myometrium, if it gets into the muscle itself of the uterus, or it penetrates through the muscle actually into the outside layer of the uterus, then again, those, as you go down this list here, become more and more dangerous for prolonged bleeding after birth. As you can see, the last one, this patient can have, in essence, of over 3 liters of volume loss just simply because of that scenario. Now, the good thing is that she's built up a lot of blood because she's been pregnant. The problem is that she's going to lose all this before she really gets symptomatic in a lot of cases. So by the time she is symptomatic, she's in really big trouble. And so we really got to be quick on trying to take care of this patient. But this is kind of what it would look like, so to speak. So the accretia, like I said, kind of gets into the muscle. The incretia gets into the muscle deeply all the way through, almost all the way. And then the percretia is where it actually goes to the muscle into the outside layers of the uterus, and sometimes actually outside the uterus itself. That's how deep the placenta goes. Most of these patients that have had any kind of prenatal care, they already know this, but you'll get those patients that have not had any, and this may complicate that scenario. So that's where that bleeding may be prolonged that you're dealing with. So to give you kind of a gauge and a baseline here, the more volume they lose, obviously the more symptomatic they're going to get. Just remembering that your term pregnant female has developed a blood volume almost 150%. So they have got at least half more volume than they normally carry. So they can afford to lose that, plus another liter or so before they really even start looking like they're symptomatic. By the time they're really symptomatic, they may have lost 3, 4, 5, 6 liters in some cases. They've lost that reserve plus their natural volume, and again, they're in bad shape. So there may be a lot for us to do. In some cases, it may not turn out very well. So other than the basics, as I said, treat it as you can as far as shock management goes to the best of your ability. And then titrate your fluids, those of you that can. Help your medics out when they get on to this point here to titrate it up to a systolic pressure around 90 or a MAP around 60, 65, and transport and get them out of there as fast as possible because, like I say, these are all surgical cases. All right, here's the second case. So we start looking at a 30-year-old female with chest pain, and she just delivered a child about a week ago. Right, so that should raise a red flag. Chest pain when she takes a deep breath. She always feels short of breath. And she's also noticing that her left leg recently has started to swell up and it's starting to become very painful as well. These are all new for her. This has never happened in the past, but since it has happened post-pregnancy, this is where it becomes a little concerning. These are your vitals. The one that sticks out here probably the most is the pulse ox. She's awake and talking to you, but yet she has a pulse ox at 83. So what this is all pointing towards is one of the other problems that we see a lot with your patients is that you have some type of embolus. And in this case, it could go anywhere, but now we're talking about a pulmonary embolus in particular. And this is the most, or essentially the second most common cause of death in those females, secondary to the bleeding that we just talked about. And obviously, when they get pregnant, because of the hormonal changes, they're more predisposed to clotting and things like that. Their excessive blood volume that they have as well, which predisposes them to clotting. The sedentariness that a lot of them have, the low blood flow in certain cases, all this backs up and makes a possibility of an embolus formation. So as you can see, the risk factor goes up, almost 5 times from being pregnant, especially second, third trimester. During the postpartum period, though, because of all the changes that we just talked about and they're trying to reset everything, during that process, it actually triples. And so now they're up to almost 15 times more likely to have a PE in that time period after birth, in that first 6 weeks, even up to the first 6 months after birth. This is kind of the whole pathophys behind it. And a lot of you that have had a patient with a PE probably looks very similar, but what happens is that little chunky monkey gets lodged into the vascular system of the pulmonary system and basically provides a dam in the river. Now, the right side, remember, of the heart is what's feeding and pushing blood through your lungs. It's a very weak side compared to the left side. So if I get this large clot or multiple clots in the capillaries, now all of a sudden I got a lot of resistance I have to push against. And that right ventricle just doesn't have the ability to do so constantly. So it tries to build muscle to get past those obstructions and that resistance. As it does so, though, it actually ends up dilating the right side of that ventricle and that heart. Now, that right side of dilation has a couple of consequences. One is that, as you see in the picture, it now actually starts to enlarge so much that it actually shifts the intraventricular septum towards the left ventricle and decreases the left ventricle's ability to fill, because now that chamber isn't as big because it's being encroached on by the septum. The other thing is that right ventricular wall stress, you would think with building up a little extra muscle, it should make it more efficient. It does just the opposite. It's more inefficient. It's like anything. If you use a rubber band and you stretch it and you stretch it and you stretch it and you stretch it, well, eventually it loses that elasticity. It's the same thing that's happening to the right wall of the heart in this case. So over time, this is where, again, it may be that delayed presentation, that resistance is still in those capillaries. That right side just starts to gradually fail and fail and fail more and more and more. All of that leads to that patient becoming hypotensive for 2 reasons. One, it's not able to push blood through the lungs and obviously to the left side, now to the body. But even more so is that pressure now starts to back build into the venous system. If that right ventricle can't push it forward, eventually that pressure starts pushing blood backwards into the vena cava and into the veins themselves, and it just kind of sits there and doesn't really move forward very much. So if the blood's sitting in your veins and not in your arteries, well, you're going to get hypotensive. Now, when that occurs, well, now your patient presents that way, so we give them more fluid. Well, by giving more fluid, what do? We just try to push more fluid into that right side that's not going to work, and eventually you get another spiral effect that allows that right side to fail, and then eventually there's no perfusion that's significant enough, and your patient goes into cardiac arrest at some point. So in essence, what you've got is a scenario where you've got your bus, right? And the bus, let's say, is your bloodstream and your blood cells. Well, if, again, you've got this large amount of blockage in the lungs, and you've got your people at the bus stop, which is your oxygen, for example, well, if you got that blockage and the bus just never shows up to the bus stop because there's no perfusion and there's no red cells, well, then your patient's eventually not going to have enough oxygen. They're not going to have enough volume. They're not going to be able to push it. And again, that heart's going to fail. And when the heart fails, your patient fails. So these are the typical things we start to see with patients with pulmonary emboli, even in the postpartum period. It's the same presentation that you get with the people that weren't pregnant. The amount of area that's damaged can vary, obviously, but your patient's always going to have some degree of shortness of breath, chest and back pain, and probably compensating with an elevated heart rate and respiratory rate. Despite all that, their pulse ox and their presentation is going to show you that they're hypoxemic and hypoxic. But here's the kicker. You listen to their lung sounds, and they're pretty much clear throughout. You watch their chest rise, and it's equal on both sides. So it is a perfusion problem in this case, secondary to a blockage. It is not an oxygenation ventilation problem per se. Okay. Again, we can get plenty of people oxygen down to the bus stop. It's just that there's not enough buses coming by to pick enough up, and that's what causes the problem. So what we do for this is more or less, again, a very simple amount of assessment, oxygen administration as best as they can tolerate, even though, again, we don't know the degree of how bad they're off. Give them as much oxygen as they will tolerate. Obviously, watch that pulse ox. You may not see it get very high at all. Get them on a monitor and obviously get your IV access, those of you that can. Past that point, okay, a lot of it's mostly going to be just watching what happens. You have to have that high index of suspicion, especially, again, we're talking about that postpartum, we're talking about the acute onset and that shortness of breath and that classic signs and symptoms that we've got there. This may be that PE that we're dealing with. So if that's the case, this turns into what I call the recognize and run scenario, right? Because there is not much more we can do for them in the field. If they arrest, okay, it's still going to be BLS and ALS. The problem is that even with good oxygenation and ventilation, you're going to get good lung sounds, you're going to get good chest rise with your ventilations. It's just the problem is we can't circulate enough volume to pick up that oxygen, which was the culprit in the first place. That didn't go away when they arrested. So that would be one of the scenarios that when you call in, make sure that you're very clear this may be what the deal is, so that the ER staff can be ready and maybe they can still do something for them in the time that they get them in the ER. It may be one of those scenarios where it's futile regardless, but we always want to give that patient the best chance. Now, another possibility is that it might be that embolus from the amniotic fluid. So it's not a hormonal issue or something related to pregnancy directly in that regard, but here it's secondary to the fact that amniotic fluid got into the maternal circulation, and this can happen for a number of different reasons. What tends to happen is that when that nastiness gets in there, could it form a clot, as I told you earlier, with the sludge and the hair and the fecal matter and nails and all that stuff? Sure. But a lot of times, the presence of that material in the bloodstream sets off what's called an anaphylactoid reaction. It's basically anaphylaxis. It's a anaphylactic type of presentation. It just wasn't caused by a typical allergen or antigen. It was caused by the presence of this amniotic fluid in this case. Right? Now, again, the numbers you can see here are not all that high, but if you ever get one of these, you'll never forget it. And it can happen anywhere from 1 to 2 days after birth. Typically past this time period, you won't see this. It still can happen, but this is kind of the danger zone. Some would even say up to 72 hours postpartum, where this may be the culprit behind your embolus in this case. Lots of different risk factors like you can see here. Got to go back to the maternal age of over 35. If they had any issues with the placenta in the first place, an abruption, previa, preeclamptic patients had any kind of trauma, or any kind of cervical or uterine tears. And this is stuff that, like I said, this is how the amniotic fluid escapes, is that it gets into these nooks and crannies that shouldn't be there from previous trauma or advanced age, or due to the fact that the uterus hasn't got the tone, or they had a C-section in the past, or they just have one of those scenarios where they just produce a lot of amniotic fluid and it leaks in because of the pressure that it puts up against the walls. Whatever it might be, these are usually dictating that this may be the culprit behind it. So when this occurs, these are the things that we typically see. And most people would say that it has to set in all four. Right? One is that the acute onset. Well, that goes without saying. So either one, the patient cardiac arrest, okay, or two, they have this acute hypotensive event with respiratory compromise. Right? So that's critical point A, number one. Number two is that they have some kind of evidence of clotting issues. That is something that has to be tested in the hospital. So we wouldn't necessarily pick up on that. The only reason we might pick up on it is that you've got someone who's bleeding externally, and regardless of what you're doing, they just continuously bleed and bleed and bleed and bleed and bleed. Those of you that start the IVs, you may start seeing leaking around the IV sites as well of blood. That may be the only indication, but to do that, that has to be tested in the hospital. Obviously, during labor or within 30 minutes of placental delivery. And then lastly, the key is that they don't also have a fever. This is just one of the criteria that's used to identify this. We're doing it on the fact of the acuity that we see with the dyspnea and the chest pain and so on and so forth. And like I said, this ends up being or looking like is a anaphylactic reaction. Okay? All that material that gets loose from the amniotic fluid gets in the bloodstream. They just start setting off a cascade of events that in the lungs, it causes bronchoconstriction. In the bloodstream, it causes a histamine release, which causes vasodilation and eventually, hypotension. What it also does is that it basically eats up, because of the large histamine release, causes all that dilation. Patient eventually runs out of platelets very, very acutely, and they have this coagulopathy, which just then prolongs any bleeding that's going on. And so that in of itself also precipitates a problem as well. So volume loss plus the respiratory insult, add those two together, and that's secondary to what we see in these patients here. So unfortunately, it's something that can't be predicted. Okay, it can't be prevented. And really, the treatment is based on what are we assessing in that particular moment. You could have 3 different people with fluid embolism and have 3 different presentations in some cases. So you see what you have, you fix what you can with what you're presented with, and then it's mostly at that point supportive, your BLS and ALS to the best of your ability, and you get them out of the field as fast as possible. Because again, when we're dealing with this postpartum as part of the history here, this may be one of those things that's on the plate, and there's only so much that we can do, and they will collapse and decompensate very quickly, even with our best efforts. So we've got to get them going in the right direction as soon as possible. Okay, here's your third case. So now we got a 38-year-old female, recently delivered her first child. She's complaining of a severe migraine, that's what she calls it, but she's never had a migraine, but that's why she's calling a migraine, because that's what she thinks it feels like. Has a really bad headache, and her vision is getting really blurry, and she's really having a hard time with the lights. So we kind of walk into this dim room, so to speak. Her headache is also making her stomach hurt, so she points to the right upper quadrant of her abdomen. And these are the vitals that we get. So other than what she's telling us, at least her vitals, I mean, her blood pressure is up a little bit, but she's in a lot of distress, so that might or might not be too high. But still, it's like, something's just not right here, because even that seems a little high, but everything else looks pretty good. So we got to start thinking about the lines of what are some possibilities here, and this is where your history and your physical exam is going to pick apart a lot of this, because she's going to be very vague, because she's only telling you what she can feel. There's not a lot of history behind her. Obviously, it's her first child, so she's never experienced anything past birth. She's got no reference point. And that being the case, there's an infinite number of possibilities that we could be dealing with here. However, as you transport her, well, sure enough, now she starts having a seizure. Big, full-blown, generalized seizure. So now, well, again, there's 100 different reasons why someone seizes, but postpartum, most people don't think, well, preeclampsia or eclampsia, because that's a pregnancy thing. Postpartum, though, it still happens. In fact, sometimes happens more often than not. Up to 6 weeks, again, in that postpartum period like we talked about. To define this, though, what we look at are a couple different things. First and foremost is that their pressure has these parameters. Either A, their systolic is over 140, and or their diastolic is over 90. Okay? And then goes, this is just by textbook definition, on at least 2 occasions, at least 4 hours apart. But she's never had a blood pressure problem in the past. That's the key. So your patient who was normally fine, now she's got these parameters of at least a pressure of 140 over 90, one way higher in one parameter or another, and has one at least of these as well. Now, obviously, protein in the urine, we're not going to be able to discern that. So maybe that's been tested prior. Maybe that was something she picked up at her OB after birth. I mean, there may be evidence of that. We're not going to see that in the field. However, we are going to pick up on the last 3. One being any kind of pulmonary or peripheral edema, So if you listen to her lungs and they sound like garbage, okay, and or she's got some abnormal amount of swelling that she says wasn't there, perhaps again, that new onset of headache. She's complaining of a migraine. She got that headache here. And or the visual disturbances, as she also does present with in this case. This is just a partial list of those possibilities: blurred vision, flashing lights, partial, what you could call partial blindness, intolerance of light, things like that. Any one of those are present, then that fits the definition of preeclampsia. Now, there are lots of reasons why this could happen. So she may also, if you get to her history, may tell you, well, I'm also diabetic, or, maybe it's a African American female. Okay, they're predisposed to it. Maybe she's also obese, or maybe just obese in herself. That's another predisposing factor. Maybe this was an in vitro type of pregnancy. Maybe she's got some type of sleep apnea that she's diagnosed with. I mean, again, partial list here, but in that history, you may not remember any of this, but when you're getting that history and you're relaying that to the hospital, they'll be like, yeah, that's probably the problem, right? So there may be some other things here that precipitate this. Obviously, the postpartum period is what we're into, is where we're seeing that preeclampsia start to manifest. All right, so what is it? Well, basically what happens is that you get a scenario where when the placenta and the uterus come together, the placenta has to be perfused, right? And when it's perfused, right, it starts creating what are called these villi, these fingers, which basically provide a connection between the fetus and mom. Okay, the villi and these spiral arteries that you see here are those perfusion points where blood goes back and forth across the membrane and takes the toxins away from the baby and takes the nutrients to it. Obviously, then mom picks them up and so on and so forth. The problem with your patient who is preeclamptic is that a vast majority of these spiral arteries do not open up. That's what you see in that middle part of the picture there. So when they don't open up, that placenta and obviously the perfusion and ability for the baby to exchange during its time in utero is compromised. And the more of those arteries that don't open up, the more likely it is this patient's going to become preeclamptic. Now, you add in her predisposition with that list I showed you, then you have on top of that the failure of those spiral arteries to open up. Right? Like I said, that placenta and eventually the fetus starts becoming compromised. Now, because of the placental ischemia that occurs, that lack of perfusion, because those arteries don't open up, now what starts to happen is the placenta starts releasing a bunch of toxins. Right? And part of those toxins cause, among other things, vasoconstriction. They also cause issues with clotting as well. Add those two things together, and what you see as a result is the kidneys start to become underperfused. The patient starts becoming hypertensive because it's making up for the toxins, and the toxins themselves that are causing that vasoconstriction are elevating the blood pressure. It's increasing that afterload, so to speak. Protein in and of itself starts to back build in the system because the kidneys can't get rid of it. And fluid gets retained because the kidneys can't get rid of it. And the blood pressure also skyrockets. So add all those things together, and that's the signs and symptoms externally that we start to see with that patient who becomes preeclamptic, and also the blood pressure issues that we see as part of the parameters. Now, if she's not treated, okay, all that eventually catches up and eventually starts causing neurological issues, and that's when the patient has that generalized type of presentation with a seizure-like activity. So that's with mom in general, and obviously the longer mom seizes, now the mom also becomes somewhat hypoxic, and that, along with the ischemia in the placenta, can cause issues with the fetus not only having growth issues, but may cause the fetus to become compromised in utero and could cause to its demise as well. So one of the other things that we see along with preeclampsia is this thing called HELP syndrome. And it's, again, somewhat common, but it's seen as a variant of preeclampsia. So you tend to see it along with it. It's not usually by itself. So the females that have it can develop this, but females that are preeclamptic won't necessarily develop this as well. It just depends on how bad that issue is at the placenta. That's kind of the variable that no one really has any control over. But it's also seen in patients that aren't preeclamptic, right? So this can happen as a result of patients that are normotensive as well. But what HELP stands for is mnemonic like this. We have blood cells that are basically being blown up. You have enzymes in the liver that are elevated, and you also have a low platelet count that results. And all of this is secondary to the fact that the liver in and of itself is what's being compromised. If they've had a history of it, obviously they have a higher chance of getting it. If they have a history of preeclampsia, this predisposes them as well. And any female, usually over about 25 on average, so basically childbearing age, for the most part, is also prone to this. So this is something that can happen. It doesn't always happen, but it can. And when it is occurring, these are the signs and symptoms, which look very, very similar to preeclampsia, as we already talked about. The only differences that you might see additionally is that A, the complaint of that right upper quadrant pain, B, maybe some degree of jaundice, which is still relatively rare. But if it's there, both the right upper quadrant pain and the jaundice indicate that the liver has been compromised, thus why this HELP syndrome is more or less setting in. So this is kind of a composite of both of them here. So if we look at the left side of the picture here, again, it all started with the fact that either they had a predisposition anyways from their risk factors, but then that spiral artery just didn't develop. They didn't open up like they were supposed to. So what happens? Well, the placenta is not getting perfused. Placenta doesn't get perfused and doesn't create these villi, these fingers, basically to create the interface between the fetus and the placenta. Well, now perfusion not only is a problem, but now that exchange is also a problem, and the fetus can be compromised, as I already told you. But because the fact that the placenta is forming but is not being perfused, it releases all those toxins. And the toxins, as I said, they act on the bloodstream, they constrict blood vessels, they act on the kidneys, and basically cause them to not only retain fluid, but also can eliminate protein. So again, more and more of that's built up into the system. So when they do pee, there's a high concentration of it. But then also as a subset, okay, the liver in some cases can be affected. And that's where a lot of your, the liver in and of itself is kind of like your recycler of your red cells anyways. So what happens is that process of recycling your red cells actually goes into hyperdrive, and an excessive amount of red cells are actually destroyed that shouldn't be, and thus the hemolysis. The liver enzymes, which are part of that process, are elevated, which causes the hemolysis, and your platelets, which normally are being developed also as a byproduct in this area, as well as other parts of the body. Okay? These toxins that are being released cause those platelets to not get formed as fast as they should be, plus the fact that your patient has also got a high concentration of clotting that's necessary, the coagulopathy that builds up. So they just run through them too quickly, and your patient starts to, again, have signs and symptoms of that DIC, excessive amounts of bleeding that can't be controlled, bleeding from, piercings, from IVs, things like that. And that may be an evidence of it as well. But here's the kicker about the whole thing. People look at this and it's like, well, why these occur really still confuses a lot of people, because if the baby's delivered and the placenta is not in the process of being used anymore, hey, it should not be an issue, because the placenta gets delivered. Well, the placenta is the root cause of the problem in the first place. So why is all this still going on? And a lot of people think that it's probably because there's just a high amount of these toxins that have been released. It's just that they stay in the system so much longer because of their level. Eventually it wears off, but it still takes time for that to occur. And if the mom's been having other issues and or has other medical problems, then that can be a precipitating problem too. So that can be an issue that we're seeing. Regardless, when mom starts to seize, right, she transitions from preeclampsia or that HELP syndrome, or both, into what we call eclampsia. That's kind of the main difference between the two. Again, can occur anywhere between 24 to 48 hours up to about 4 weeks post-delivery. So this is still in that postpartum period, and it is still very likely. A vast majority of those patients that do become eclamptic actually do have that occur in that postpartum period. And this also, again, we talked about how bleeding is a major contributor to maternal death. This is about number 3, okay, outside of a PE and bleeding being 1 and 2, or 2 and 1, right? Eclampsia, the results of that tend to be number 3. So What can we do about it? Well, this doesn't change a whole lot from your patient that we've heard about before. Seizure precautions, obviously get them on their side, prevent any kind of airway issues, try to keep the airway patent as best as possible. And obviously, you know, lateral recumbent is always going to be the best thing to do for them. Oxygen as necessary, depending on the needs of your patient. Those of you that can, we get our line started. Obviously, we get them on the monitors. And then once we do, and if we've carried it and it's in your protocol, then we start to terminate that seizure with the mag sulfate. Now, there's a couple different ways you can go about doing it. Obviously, you want to follow your own protocol, but the key is that most typically your loading dose is going to be IV, and you're going to give 4 to 6 grams over about 15 to 20 minutes. So it's going to be an infusion. That should be enough. The smooth muscle relaxant properties of this will help with the blood vessels. It will help with the bronchoconstriction. It will help also tampen out some of the bleeding as well. So all that can work together and restore, among other things, perfusion to the brain, which is being hypoperfused, and that's why the seizures are occurring. That may be enough. If you don't have the IV started or having a hard time getting it started, then there is an option to go intramuscular. Basically, you're going to go in the buttock. So pick a cheek. You get 5 grams per cheek, and you give 10 grams total that way. Now, the onset of your relief is going to be delayed because it's intramuscular. It may be a little bit longer before you start to see a resolution, but still, it doesn't preclude you from getting those IVs started, those of you that can. Otherwise, again, if you have your favorite flavor of your benzo, you can pull that out, and that can help with temporary seizure control as well. But the mag sulfate in this particular case, for this particular type of seizure from an eclamptic issue, should be managed with mag sulfate. So the last case. We talked about quite a few things already. This one here is the one that you may or may not ever see. I've never seen it, but like I said, I had 5 females that came up to me after the first time I did this, and I was like stunned. But here's her case. So 28-year-old mom of 3, so she's had birth in the past, delivered 10 days ago. She's now complaining of increased shortness of breath. She first thought it was kind of a cold, thought she might have pneumonia, but she hasn't had a fever, but her shortness of breath has really gotten worse, and now she's starting to cough up this pink frothy sputum. So there's one of your big red flags right there. Last 2 nights, she's had to sleep using a recliner, so basically sleeping kind of sitting up because she can't sleep lying flat. Doesn't have any swelling, though, and otherwise she's been perfectly healthy. There's your vitals. And again, 28 years old without any kind of major history, and she's got a blood pressure like that and a pulse test like that, I'm a little concerned. History here has something also, some points that I need to look at. Again, the increasing shortness of breath, the pink frothy sputum coughing up, having to sit up or be propped up because she can't lie flat. All those things are very suspicious. And it sounds like, and it smells like, and it tastes like someone's got CHF. And for the most part, that's what we're dealing with. But what we call this, because of this particular scenario, is what's called peripartum cardiomyopathy. All right? Again, as you can see, it is a very rare condition, but it is a cardiomyopathy, abnormality, left ventricle, due to the fact she was pregnant. And because of the fact that she, among other things, she's carried so much volume for so long, some females end up in this condition. Lots of cardiac issues that can follow with this, ranging anywhere from heart failure, like she's presenting with, up to, in some cases, a cardiac arrest. Now, how this gets defined is that A, it's developed usually in the last month of pregnancy and or the first 5 months after. So this goes into that whole period I talked about, that delayed area. And this is where, yes, we typically see it in the first few weeks up to maybe the first, 6 weeks, but it can be delayed enough that here we are. Remember, she's now already had 3 other kids. So this may be one of the things that just simply because the multiple pregnancies may have caused this as well. Again, no history of heart failure in the past, no heart disease in the last 5 months. And this would be, again, an in-hospital thing where they do an echo and they find that she's got an ejection fraction, which is pretty low. So 3 of the 4, also, again, we can figure out from our history, and this may prompt the ER to be like, look, don't bring them here. We don't know the OB capabilities. We don't have heart capabilities. Take them to such and such place. So this may affect your transport decision as well when you're in the field. So that's something that you want to make sure you're very clear when you're radioing this in. Risk factors, again, lots of them that are similar to some other things we've talked about. African Americans tend to also have this. Again, genetically, this tends to be somewhat of an abnormality, very similar to what we see with African American males with sickle cell. Why they're predisposed to it. African American females, this may be one of the things they're more likely to get simply because of genetics. If they're a smoker, if they've again multiple children, we've already seen, they're diabetic, overweight, they had a history of preeclampsia or hypertension, all those can lead to this developing as well. Now, why does it happen? Well, nobody really knows yet. There are lots of theories out there. Some may think it's secondary to a infection of the heart called myocarditis. But mom's didn't have a temperature in this case. She's never had any problems. So that's probably not the case here. But we think about recently with all the issues with COVID. And we saw, especially with kids, not so much in adults, but it had happened in adults, where there were multiple cases of myocarditis being discovered, which is really abnormal. Right? So maybe now we start to see that in some of these females that have had COVID. So that's a possibility. There could be a thing where, again, either hormone imbalances or the fact that she was pregnant and a excessive release of prolactin from the pituitary, along with their history of maybe being hypertensive or a genetic component, that could cause it. Might be in some cases. It might be simply because they were hypertensive in the past. It might be because of the fetus themselves. So maybe we look at that amniotic fluid embolism. Maybe those components, maybe this down the road from one of the previous births, maybe this led to it. That could be a possibility. Or maybe it's just mom's not really malnourished. Now, in this country and a lot of the developed countries, you're probably not going to see this. But there has been a correlation with low iron and selenium levels that can predispose this to happening as well. So it could be any of these things. It could be a combination of these things. No one really knows. And even with the literature that's out there, no one's really put one specific spot on, okay, this is it. So with the variables that are out there, A, it makes it rarer to occur, but B, it also makes it harder to diagnose. So this is what's happening. You know, you see the normal heart on the left there versus the dilated one on the right. It just decreases the efficiency of that heart to contract. The muscle gets thinned out, it gets stretched out, it just doesn't snap back like it should. So the output and, like I said, the ejection fraction, which is the amount of blood that's pushed out, stroke volume and things like that, all of that gets affected because of that inefficiency of that left side and eventually the right side of the heart as well. So this is what we get. Very similar to what you saw in some of the parts of that case. You know, the cough, the fluid backup, because again, this is heart failure, and left heart failure leads to hypertension in the pulmonary system. And when that fluid backs up in the pulmonary system, it causes those capillaries to leak, and sure enough, they get the pulmonary edema, they start bringing it up, and here we go. The inability, again, to lay flat, because the heart now is affected by gravity. It's working hard as it is, now you add gravity into it when they lay flat, it just makes that fluid stay retained and not move forward even more efficiently. So they may have that, or that paroxysmal dyspnea where they woke up in the middle of the night, short of breath. So that may be part of the presentation. You'll see some degree of JVD. You'll see some degree of peripheral edema or liver enlargement in some cases. As far as the monitor goes, not a whole lot of changes. Those of you that can do this, you might see some nonspecific ST changes that, again, would be indicative of it. You might see evidence of left ventricular hypertrophy if you look in the V1, V2, V5, V6 leads as well, and their 12 lead, and or just low voltage QRSs with inverted T waves, which usually starts to make us think of ischemia in the initial stages of it. And with a patient presenting a chest pain, it very well might be, right? But it might also be something related to this as well. So the pregnancy is, again, the big red flag in this whole entire process. To manage it, you manage it just like you normally would with your patients in CHF or pulmonary edema, however it is that you can based on your level of care. Keep your patient sitting up. CPAP would be one of the things we might consider, which just about everybody can do. Trying to reduce the preload, those of us at the advanced level with your diuretics and nitrates and whatever the case may be. But most of these patients with an advanced case tend to be a candidate for a ventricular assist device, and or some may need the transplant. Now, out of the 5 ladies that I talked to, all 5 of them remarkably enough, did not get to that point. They are being managed medically now. One was going to be a transplant or a transplant candidate, but had not got it yet. But they were all still at the conference. They were still able to get up and get around and everything because they were being medically managed. 3 of the 4 had it resolved all by itself. So it's one of those things that now we're dealing with the acute issue here, and that's what we're going to have to deal with when we see these patients. But this may be one of those possibilities. Okay. So regardless, just to kind of wrap this up, what we see is what we've got. But keeping that issue, the fact that this patient was previously pregnant, can cause a lot of these problems we talked about, the more common ones that you would see. So keep that high index of suspicion. Keep those things on your radar until they're proven otherwise. But again, we want to get them to that specialized care. We want to get them there as soon as possible. So with that, I'll see if we can answer a couple of questions real quick because I know we're right at time here.
All right, let's see. Yeah, we're just about over time, but we'll go through here. I think I know the answer to this, but I'll ask it. Is there any specific testing the hospital can do to confirm a source of a PE, or just know that they have a PE? Like what type of?
Usually they'll use a test specific in the hospital that they can scan for those things. They can also do a D-dimer or something similar to that. So they've got a couple different ways in hospital they can pretty much pinpoint a PE, but those things also take time. It takes time for those lab results to get back. It takes time for that scan to occur. So your clinical judgment.
Whether it was an amniotic.
Or the amniotic one?
Yeah.
The amniotic one, simply probably because of the pregnancy, that's where I would keep the suspicion. Yeah. But the amniotic fluid embolism a lot of times is not going to cause so much a blockage like a normal PE. It's going to be more presenting like that anaphylaxis-ish type of presentation.
All right. Well, we just in the sake of time, give everyone a time for a quick break. Thank you, Chris. Lots of good feedback on here. Everyone really enjoyed the presentation, it looks like. And again, there's Chris's information if you want to send him any more questions. I'm sure he'd be happy to respond to your email.
Yeah, feel free. Be glad to. And if you want either one of these presentations, if you're in both, you're more than welcome to them. Just get a hold of me and we'll make sure you get them.
Okay. Well, thank you, sir. So we will take a break and we'll see you all at 5:15 with the last presentation.